Health Canada has authorized for the prevention of COVID-19. In fact, Canada is the first major regulator to have authorized 4 vaccines: Pfizer-BioNTech, Moderna, AstraZeneca Serum Institute of India, and Janssen. The U.S. Food and Drug Administration approved the Janssen vaccine just a week ago, and it's currently under review by other major regulators. During this technical briefing, I'm going to provide you with some details about the Janssen vaccine.
Approved and only needing 1 dose. Is that looking to go to potentially First Nation communities because of that accessibility? And do we know a timeline as to when we could get them here in Manitoba?
Yeah, so we heard, I think actually the press conference from Health Canada might be going on right now. And so, we've heard broadly that Health Canada has approved the Johnson & Johnson vaccine, but we haven't received any other official details regarding how it's going to be recommended to be used, who will be prioritized, nor how many doses or when those doses will be available. So I would say right now we're not able to create any determinations about exactly how that vaccine will be used because we don't know when or how much we'll be receiving, nor even who NACI will be recommending we use it for.
Great, perfect. And I know you had just mentioned by next week hopefully getting to 80 and above, moving that number down for the general public. What about your optimism at this point? I mean, at the beginning, we had just Pfizer and then Moderna, and now 2 other ones get, AstraZeneca and Johnson & Johnson. What's your hope for getting all Manitobans vaccinated and potentially even having a semi-normal summer here?
Yeah, I mean, I'm certainly optimistic that we will be able to offer all Manitobans a vaccine by the end of June. I believe that there was a technical briefing earlier today that went through some of the more detailed planning that we're doing as far as what assumptions that we're making. But the more vaccines that are approved, the more likely that that June date becomes. And if multiple vaccines continue to be approved, we might even be able to move it up earlier than that for the first dose. Certainly we also know that we need to plan to provide the second dose as well for Manitobans. So even once we've got that first dose in, our work is not done. And we want Manitobans to plan to receive that second dose once we've gotten through the next few months.
From the Brandon Sun, Colin.
Hi there. I was wondering, what has the uptake percentage among First Nations people for vaccination been like so far?
Thank you for that question. We do not have the ability to calculate the uptake percentage yet for a variety of technical reasons, but I can let you know that as of today, over 9,000 doses have been administered to First Nations people. The number that have received second doses has increased as well. That information will be released in our dashboard today at 12:30, as well as on the AMC weekly Facebook Live for more details. We have had anecdotal reports that uptake has been very good amongst the elders and community who have been eligible to date, and we look forward to working collaboratively with our partners to continue to produce and refine data on the vaccination uptake and coverage.
How has your communication campaign to prepare First Nations communities for the vaccination effort gone?
Again, we've received very positive feedback on the vaccine information that has been shared. Since the beginning of the pandemic, we've worked with our First Nations organizational partners, including AMC, MKO, SCO, FINISM, as well as directly with communities doing community radio, NCI, APTN. So we have been, I would say, very proactive with those communications. And we also draw on resources by other First Nations organizations, and I'll just mention one, First Nations Health Authority, for example. There's also a targeted Indigenous specific campaign out of Women's College Hospital in Toronto. And so we are doing both our own as well as sharing the excellent information materials from others, and are receiving very positive feedback on the information that's being shared.
From CJOB, Will.
Hi, good morning, everybody. Dr. Reimer, how long do you expect it will take to distribute the AstraZeneca vaccine to clinics and pharmacies? And can you tell us how many sites you expect to ship to, please?
Yeah, I don't have the final allocation for all of the sites that we'll be giving the first shipment to. And so we'll be working on that and finalizing it today and sharing it with all of the pharmacies and clinics that will be getting a shipment with this first round. We do anticipate receiving 18,000 doses of AstraZeneca probably next week, is what we're being told by the federal government. And so we will be distributing all of those doses out as quickly as possible as soon as we get them. Because we want to have our physician clinics and pharmacies reaching out and immunizing Manitobans as quickly as possible after they arrive in Manitoba.
Okay, thanks. And Dr. Anderson, with the teams heading to each First Nation community, I'm wondering how long are they expected to remain there? Like, how big is the window for people there to get the vaccine?
Yes, thank you. So the total window depends on the parameters of the vaccine. And so at this time, we're planning really for Moderna exclusively, although that may shift a bit depending on supply. But right now, our planning is focused on Moderna. So we will have 30 days to use the vaccine once it leaves the freezer at the warehouse. As I mentioned before, some communities have assets and will start their vaccination programs before the surge team comes in. When we're doing the calculations for how many fit team members will need to be there and for how long, we make some different planning assumptions. So we assume that each immunizer will be able to do about 4.5 vaccines an hour and will work a 7-hour day. So the length of time that the team is there in total depends on the size of the over 18 population in the community. The number of team members who can go and can have accommodations, since accommodations can be limited in some of the communities as well. And then the days that they will be in the community will really be based on those two factors. So it will be different from community to community depending on the size of the population to be immunized.
From the Winnipeg Sun, Josh.
Good morning, doctors. My first question is for Dr. Anderson. You mentioned a lot of logistical challenges on getting the doses up to the north for some of those more remote communities, and that's why you're kind of focusing on them first. But when we look at second doses and getting those doses up there, would it have made better sense to make sure that we get those where access might be more difficult, get the second dose up to some of those more remote communities first before focusing on where the logistics are a little bit more simpler in the south?
So in terms of the second doses from our first phase of the rollout, by the end of day today, all 63 communities will have received their vaccine shipments for that first phase rollout. When it comes to our planning for this next phase, where we're doing the whole population 18 and up in an evidence-based sequence, we will be starting with communities both in the southern part of the province as well as in the northern part of the province. So we want to ensure that our Southern First Nation communities are hearing the message that they don't need to wait for the entire north to be done before they get access to vaccine. There will also be Southern First Nation communities starting their community-based rollout this month as well. We are still examining the prolonged interval that Dr. Reimer has referred to. We are planning to complete all first doses before we start the second doses, as Dr. Reimer has also said on behalf of the province, with some of the logistic challenges. And in our case, because we're deploying from the Rady Faculty of Health Sciences and, for example, planning to draw heavily on the health professional learner population who has been very willing to be part of the effort, we know they're going to need to be back in classes around August, mid-August. So we do add that level of logistic planning for our second doses as well. But I will just say that in line with the province, our plan is to complete all first doses in all 63 First Nation communities before we start those second doses.
Thank you for that. And my second question is for Dr. Reimer. And I know you don't have a lot of details on the Johnson & Johnson vaccine, on how much you will receive. But this is a different vaccine than what I think we've seen before. It's a one-shot vaccine, and it sounds like it's going to be a lot more easier to move around. It doesn't require the super cold storage. How does this change the approach for the vaccine task force in terms of getting vaccinations out to people? Is this going to be focused then more on some of the remote communities as well, or will this be looked at for some of the super sites?
So the intention for fridge-stable vaccines like AstraZeneca, like Johnson & Johnson, is to take advantage of the existing infrastructure that we have for our flu campaigns and for all other vaccines. We have a lot of very experienced immunizers in physician clinics, in pharmacies, who have a lot of expertise that are excited to get to participate in their settings. So our intention at this point is to use what we call the distributed model, or the physician clinics and pharmacies, for all fridge-stable vaccines. But we're also open to shifting approach if, say, we got a large volume of those vaccines. Perhaps we would consider doing it concurrently at the super site if we had a lower availability of the mRNA vaccines. So for now, the plan is to send all of the fridge-stable vaccines through the distributed model, but we would be open to using the super sites if we were seeing that we had a large discrepancy between the availability of different types of vaccines. Otherwise, we really want to use the existing expertise and infrastructure that has worked well for us for decades.
From CBC Radio Canada, Matthew.
Thanks. I don't have a question.
Okay, from CBC Manitoba, Bart.
Hi. First for Dr. Reimer. Dr. Reimer, forgive me. For television, we do need you to repeat on this camera here what Mr. Bosa said this morning. Could you please go ahead and repeat what he said about May 18th and June 30th in a full statement for us? Thank you.
Unfortunately, I don't have his statement in front of me, so I won't be able to repeat exactly what he said. He does have a PhD, so you can call him doctor. That's also okay. But I'm certainly optimistic that with our high dose assumptions, that we could potentially reach all Manitobans by the end of May. But it really depends on when those vaccines come in. We've received estimates from the federal government about how many we expect in Q2, but not when in Q2 those doses might come in. So it's certainly possible that we might see a large shipment at the end of Q2, in which case it would take us until the end of June to reach all Manitobans with their first dose.
Thank you for that. And Dr. Anderson, I know you were asked this slightly earlier, but given that Johnson & Johnson is a one-dose vaccine, and given that some of these more remote communities are very difficult to reach, and I'm thinking about the ones in the far northern remote areas, would there not be some advantages to holding off until you can get Johnson & Johnson, that you don't have to go twice at all?
You know, certainly as NACI releases its recommendations, and we will review all of the scientific evidence around its efficacy as well, we can consider whether or not we want to shift some of the doses. However, I would say we would not support an idea of holding off our current approach or rollout while we wait for that, and while we wait for not just the evidence and the recommendations, but also the specific allocations of it. We did have the opportunity to try the rollout to 63 communities with Moderna already once. And so we have some learnings and some successes to build on. And we are confident that we can do this again for the entire community-based rollout that we're talking about now between March 15th and roughly early to mid-May. The one opportunity I see as potential for either AstraZeneca or Johnson & Johnson is maybe to have available for people who miss their community-based vaccination clinics. They may be out of community, for example, for medical reasons or medical travel, or if they're acutely ill during the vaccine campaign and are unable to receive the vaccine at that time. Perhaps that is an opportunity we can explore with the vaccine task force to have some doses available at mRNA clinic.
From the Canadian Press, Steve.
Oh, hi there. I'm wondering, with the new time frame that we were briefed on this morning about potentially somewhere between mid-May and the end of June for a first dose, what can you tell Manitobans about what that might mean for a second dose? Because the second dose might be up to 4 months later, correct?
So the plan that we've made so far is dependent on the supply that we get through the federal government. And so, this morning, I know that there was some discussion around what our planning assumptions lead to, and whether, with a high supply situation, that we might be able to reach all Manitobans in May. But if the doses that come from the federal government appear in June, then obviously we would need to be waiting until June before we could reach all Manitobans. So we're comfortable with the evidence that we have today to delay the second dose up to 4 months. But we'll be watching the evidence to determine if it continues to be safe to do that, or if there's any evidence that people's immunity is decreasing. Likewise, we'll be watching to see whether or not the second dose might be more effective if we wait a longer period of time. We have seen that in other vaccines, even in the AstraZeneca trial. We saw that the longer delay between the two doses helped the second dose be more effective or more efficacious than the earlier dose. So right now, the plan is certainly to start dose 2 when we've completed dose 1. If that's earlier, if it's in May that we complete dose 1 for all Manitobans, then we would move on to dose 2. We have no intention of slowing down or shutting our clinics down, but rather would move on to dose 2 as soon as we can, unless there's some data showing us that there's a health benefit for Manitobans to continue to delay the second dose.
Thanks, Dr. Reimer. And as a follow-up, some Manitobans might be worried that, as of today, nobody's booking a second dose appointment. That might create some uncertainty. So what can you say to assure Manitobans that there will be a second dose and the effectiveness of the first dose as we're getting more scientific information in?
So we're very confident in the data that we've seen so far regarding the effectiveness in the real world of the first dose. We've seen data from BC, Manitoba, Quebec, the UK, Israel, and all of them are showing that after one dose, we see real-world protection of 70–80%, which is very good. That's when we look at those numbers in a real-world setting for a vaccine in public health, we're very happy to see that, because we know that if we could reach all Manitobans with a vaccine with that level of effectiveness, we would be able to get rid of the circulating virus. We would have what we call herd immunity, meaning that we start to protect each other if we don't carry the virus. And so while we're being cautious and making sure that we continue to watch the science to make sure that that immune level stays high, we're also very optimistic based on what we've seen so far in all of those places that I just named, that this will protect Manitobans. But we also think the second dose is very important. So just because that first dose is providing a good immune response and protection now, doesn't mean that we don't need to get that second dose for everyone. The second dose not only can boost the immune response, so can make your protection better, but it also lengthens the time that your immune system remains aware of that virus and ready to fight the virus. So the second dose becomes particularly important when we're thinking longer term. And the last thing that we want is to have the same experience in the fall that we had this fall, where we start to see cases go up and we have to shut down businesses and tell people to stay home. We absolutely don't want to do that again. So that second dose for that prolonged immunity is really critical. So our intention is not only to ensure that it's available, but to really support Manitobans and encourage them, strongly recommend them to get that second dose for all of our benefit.
From CTV Winnipeg, Michelle.
Hello, I'm just reading this release on the First Nations rollout for the community-based clinics. It says that 47 Northern Affairs communities will be included. That includes Métis and other First Nation and non-Indigenous populations. I'm just curious, what sort of discussions went into adding these in if they weren't already in the scope of this campaign before?
So one thing I think it's important for people who maybe are less familiar with some of the geographical aspects of First Nations communities in Manitoba and the history of some of the First Nations communities in Manitoba is that many actually have adjacent communities, and they're referred to in the news release as Northern Affairs communities, although they're not all strictly speaking in the north. And for a variety of reasons, in the way that colonization has impacted both First Nations and Métis people, those communities often contain large populations of Métis and First Nations people, as well as non-Indigenous people. Now, in remote First Nations communities, however, the nursing station is often and mostly the only healthcare provider. And so those adjacent communities always get their health services through that nursing station in these communities. And so with the larger vaccine planning rollout, it made the most sense to use the usual healthcare service route, which is the nursing station or health center in the First Nation community provides service to everybody in that proximity. And so that is the principle that's being followed with this rollout.
Thank you. Dr. Reimer, I'm wondering if there's any evidence to show that it's okay to delay the second dose for everyone. And by that I mean, like, are there any populations where we know that we should be getting that second dose sooner?
That's a great question. Thank you for asking that. So what we're basing our decision on is the data that we saw from BC, Manitoba, Quebec, the UK, and Israel. In all of those settings, elderly individuals in some way or another were prioritized. So if we're looking at the Canadian jurisdictions, it was largely personal care homes, and in the UK, a more broad elderly population. And so the elderly people are where we worry the most about a strong immune response. We know that as people age, their immune response becomes weaker, which is why we were so concerned initially with getting the second dose for all personal care home residents in case they did have a lower immune response. The trials that were run by the manufacturers didn't focus on elderly populations, and in some cases didn't even really include them. So we initially didn't have any data to tell us how elderly Manitobans might respond and whether or not that first dose would be effective for them. But we saw very clearly, and particularly in the Canadian data, because personal care homes were targeted in all of those jurisdictions, we saw very clearly high rates of protection in those settings, which was incredibly encouraging. So the group that we worried the most about an immune response had a good immune response. In one of the jurisdictions, it took about an extra week before they reached that full immune response. But that extra week wouldn't have any impact on the timing of the second dose. Just something to keep in mind that it takes a little bit longer for an elderly person to potentially build that immune response. So there was no population that ANASI recommended we take a different approach with, because the highest risk individuals seemed well protected by the first dose. But we would continue to watch that and see if there's people who have really unique circumstances where perhaps they're having, a transplant that could have a large impact on their ability to mount any immune response. And we might need to make some individual assessments of people's needs when they have these extreme examples of an immune response or lack of an immune response. But broadly speaking, the data has been very encouraging that all Manitobans should be well protected, even as we watch to get those finer details.
Our final reporter this morning from CityNews, Jonas.
Good morning, doctors. Dr. Reimer, first question for you. For folks that may be looking at, the effectiveness of AstraZeneca and seeing that 62% number, just maybe a clarification for folks that may have concerns about its effectiveness or what this could mean as it does roll out to doctors and pharmacists.
Yeah, I'm really happy to talk about the AstraZeneca numbers because they're confusing and they're complicated. They're more confusing than the other manufacturers, which I think are already difficult to understand. AstraZeneca ran essentially multiple trials in multiple countries and found a pretty large variety of efficacy depending on what setting their trial was in. So the 62% represents an overall count of most, but not even all, of the participants in these trials. What we've seen in the real world is actually a higher effectiveness than what they saw in the trials. So the data that we've seen from the UK so far has been very reassuring that the effectiveness was more than the 62% in the elderly populations and all populations that had been immunized in the UK. And this is something that, it's sometimes surprising to see a higher effectiveness in real world, but it's not surprising to see differences. The trials are done with different populations in different countries, with different amounts of virus and different variants of virus circulating. So comparing them head to head doesn't necessarily reflect how well they work. And so what we are now seeing when we really use them is they're all showing strong effectiveness after that first dose. And in particular, because we've targeted elderly people first, that's an additional reassuring point that the people who we were the most worried about whether or not it would work in are experiencing that protection. So I wouldn't focus on the 62% at all. There's other numbers in the trial. For example, 100% of people in the AstraZeneca trial avoided hospitalization, and there were no deaths in those who received the AstraZeneca. And really, that's incredibly reassuring as well. And in the UK, we actually saw AstraZeneca did better than the mRNA vaccines at preventing hospitalization and death. And at the end of the day, that's really the goal here. I mean, it's a wonderful bonus to prevent mild illness, but we wouldn't have, shut down society if we had a regular cold circulating. It really was about protecting people from those severe outcomes, which AstraZeneca appears to do very well. So the numbers are going to continue to change. We're going to see different numbers from every study that gets done on these. But what I can say consistently across the board we're seeing is that all of the approved vaccines have been safe and have been effective at protecting people from the severe outcomes of this virus.
Thank you so much for that clarification. I think kind of important for this one. And just as we move towards the doctors, pharmacists rollout, again, a message to parents or, folks with underlying conditions that, now is maybe not the time to start calling your doctor. Maybe just a general message to folks that maybe a little patience for a week, or what would you say to them?
Yeah, so I stole Dr. Roussen's line of now is not the time, and so what I'm referring to is now is not the time to call your doctor or your pharmacist to see if you're eligible, because they don't yet know how many doses they're getting, and they're only today receiving the list of health conditions. So we need to give them a little bit of time because every pharmacy and every clinic is going to have their own process that's the most efficient for them. to make sure that they are reaching those high priority individuals. So some of them are going to want their phone numbers to be available so that people can call. Some are going to prefer to reach out to their own patient population who they're aware of has these high risk conditions. So next week, once they've had time to know how many doses they're getting and approximately when they'll be coming, and know who should be targeted, that's when we'll start to provide that information to Manitobans about who we want to prioritize and how those clinics and pharmacies want to be contacted.
Thanks, everyone. This concludes our media briefing.